Assalamu alaikum and good morning, everyone. We'll start off the day with a few basic concepts. In fact, this one is not originally my lecture. One of our colleagues at the Royal Liverpool course, one of the chief's sisters, presented this. This is basically preparation of ERCP patients for a day case. Because traditionally, most of my lists have been in the afternoon, so I admit my patient after the afternoon list because there's not enough time to discharge them. But even now I've converted my list to the morning list because you can do them as day cases, especially with pressure on beds. It's advantageous to do ERCP as a day case. And if you allow them 4 to 6 hours in hospital post-procedure, then it is quite safe to discharge them home if they are well at the end. So usually, if you have to do them as day cases, it's always a good idea to assess them beforehand. We call that as POAC, Preoperative Assessment Clinic. So it's usually run by the nurses, specialist nurses, who assess the patient basically for any risk factors. If they are on anticoagulants, they are on any medication that would interfere with the procedure, or antiplatelet agents like aspirin, clopidogrel. So they are usually assessed, their bloods are checked. So, basic investigation like ECGs are carried out. It is important to find out if they've got anyone to take them home, because if you give them sedation, they can't drive back home. So they need to have an escort with them, and they need to have somebody who can stay at home with them. And we tell them not to sign any legal documents for 24 hours, because if they are under effect of sedation, they can potentially. Yes, yeah. Well, she'll make them sign everything. So basic blood test, nothing special. Any medication they are on. At the Royal Liverpool, they used to give them oral antibiotic prophylaxis before the procedure. I tend to give intravenous in my unit. They are given consent form. They are given full explanation of the procedure. Any side effects, any risk factors are discussed. Now, basically, we'll talk about consent. It is part of our assessment as well in the DOPS form, and there is a structure to consent, which I think it would be a good idea for you. Legally, the legal aspect of consent may be different in this country, but the general basic framework is the same everywhere. So what are the key components of informed consent? I'll go through that. Patients should have sufficient information to understand the procedure, its benefits, and the harm that may arise from it, right? So informed consent is that the patient is able to understand, retain, use or weigh the information given to him, and make a decision on the basis of that, and also should be in a position to communicate his or her wishes. Patient is then competent to, if he's competent to take that particular decision, then according to British law, he has got mental capacity. So consent can only be given by somebody who's got mental capacity. We normally presume that the patient has mental capacity unless proven otherwise. It is most important that when you are consenting a patient, he's not under any pressure, duress, or forced into a decision. If he refuses at any time, then there's nothing you can do. So they have the right to choose alternative treatment, refuse treatment, or withdraw their consent at any time. So if they've signed a paper, it doesn't mean that they have to undergo the procedure. They can still come out of it. So if you are going to, it is good practice not to consent them in the endoscopy or the operation theatre. They should always be consented outside, because if they are consented in the endoscopy unit, they are under some sort of a pressure or duress.
For our practice, I think because a lot of us don't have separate rooms and all in endoscopy, when you see the patient in the clinic, when is the best time you decided this patient needs the ERCP, the whole thing, and you take a verbal consent at the same time. So as you are explaining the procedure that's the kind of, it saves you doing it once. You can do that right away, and then, when they come to the unit in my own practice, that's what happens.
Yes.
They come and then they will be told again and they sign the system.
Now, the day cases, the way we have all these referrals, we see them on the day of the procedure.
Right.
We get to explain the procedure, like not obviously in the procedure room.
Right.
We see them explain the procedure, get the consent. So it depends on what type of practice you got. If you see them in the clinic, that's the best time to get them.
Because for most of the standard procedures like OGD, colonoscopy, sigmoidoscopy, we send them postal consents. We send them a big sort of booklet with information and consent in it. So it depends on how you carry it out. Now, even if you make them sign the consent form and everything, it is still not legally binding consent. In British law, the consent, even if you've not taken a written consent, the consent process starts the moment you see the patient. If you have seen the patient in clinic, assessed him, and explained the procedure to him, and documented that in the patient's notes, that is a valid consent. Even if you've not signed an actual consent form, because the whole consent process has been completed, and if the patient, after that explanation which has been documented, comes to the procedure, that means that he is doing it under, is consented to the procedure. So, but, for cosmetic reasons, we all make them sign the consent form. So, basically, I usually teach them, the fellows to follow the embrace structure. E is for explanation of the recommended procedure. M is for motive or reasoning behind the medical recommendation. Like, with E, you explain what ERCP is, the procedure, what it involves, the motive why you are doing it, because there is biliary obstruction or, there's suspected stones or a stricture. Benefits, why you want to do it, because you might be able to relieve the obstruction or get rid of the stones or put a stent in. Risks, what possible risks are involved with the procedure. Alternatives, like you can have MRCP done, but it is not a therapeutic procedure. You can have a CT scan done, but there are limitations. So any alternative procedure, you must tell the patient whether they are good or bad and their limitations. Complications, and to complete the embrace thing, you put effects on it. Effects, basically, you tell them the side effects of the medication that you use, like midazolam, pethidine, whatever you give them. Right. What happens if your patient withdraws consent during procedure? So what do? Competent adult patients are entitled to refuse treatment, even where the treatment would clearly benefit their health, even if you feel that the patient definitely needs that procedure, and if he refuses it, there's nothing you can do. It is their choice. If you look at ethical framework is composed of 4 components. First is beneficence, which is doing patients good. The second pillar of ethical framework is non-maleficence, which is first do no harm, which is the first part of the Hippocratic Oath. The third is autonomy, and the fourth is equality. According to British law, autonomy supersedes everything else. Even if it is beneficence, it is non-maleficence, but if the patient does not want to have it done, then that is his decision. So you have to respect that. Laws might differ in different countries. I think over here it might be beneficence and non-maleficence. So it depends on what law you are following. If the patient withdraws consent, in unsedated patient, you are required to stop the procedure there and then. You can't legally, because if you continue with the procedure, then that can be termed as assault. In a sedated patient, obviously the judgment of the patient is in doubt, so at that time the endoscopist must act in the patient's best interest, and that is during the procedure. If the patient is having pain or discomfort, you are required to pause, attempt to regain cooperation of the patient, like if he is distended with air, suck the air out. If you are performing a colonoscopy and the patient there are quite a few loops forming in there, try to resolve those loops and make the procedure more comfortable for it. talk to the patient, give them extra sedation if needed, or we use Antonox as the additional painkiller in colonoscopy. So you can give them Antonox inhalation and wait for the effect. So calm down, slow the procedure down, give them extra sedation if needed, reduce all the discomforts that are possible, and then if the patient agrees, you can continue. But if this patient, after all those maneuvers, is still adamant, he doesn't want the procedure, then you must terminate the procedure. Right, so basically the do's and don'ts of consent or assessment, right? So I think I'll just skip through that. Now there was a thing called NC-POD because even in UK the practice of endoscopy was quite unregulated about 10, 12 years ago. So there was a national confidential inquiry into patient outcome and death. The surgeons took a lead on that, and they did that, and they revolutionized the whole practice of surgery there. And this thing was then taken up by the endoscopy practice as well. And that was the aim of the study, was to improve the quality of therapeutic gastrointestinal endoscopy services. And the outcome was that we made sure that there were fewer inappropriate procedures carried out, lower morbidity and mortality as a result of the procedure. There was better training facilities, and the needs for training were identified, and recognition of poor performance. In the past, you could get away with murder and nobody would take. I used to have a vascular surgeon performing endoscopy list next door to me. I mean, why would a vascular surgeon need to do endoscopies? But it was one of his lists, and he used to do it, and do it badly. Reduced litigation because of you made the whole process more transparent. If I am performing endoscopies, I've got my whole year of audit data behind me. Every year, my department publishes my performance figures, so anyone can access that due to Freedom of Information Act. So it's nothing hidden about me. You can go online and do it on my hospital site. So, like in ERCP, this is gross numbers. Not necessarily procedure related, 37% death in the first week post ERCP, because some of these patients have got malignant diseases, some others. So 88 patients out of 237 patients in the ERCP sample died, 30% in the second week. So then as a result of this, was the first time they looked into the practice of endoscopy. So a lot of issues were identified. And the good thing about those countries is that when they carry out the audit process, they pick up the issues and then they act upon it. And that's how you make improvement in your practice. Because as I said, even in UK, our practice was pretty unregulated, not anymore. And there were some very simple recommendations that were made. Pulse oximetry following procedure, oxygen supplementation, better monitoring, like ECG monitoring, blood pressure monitoring during the procedure. So, to sum it up, they said that above all, to provide timely and optimal care in the best interest of what is a significant proportion of sick patients in every hospital. Because when you carry out procedures on patients, especially like ERCP, either they are septic, they may be in septicemic shock, they may have acute pancreatitis, or they may be deeply jaundiced because of an underlying malignancy. So these are inherently sick patients, and if you carry out invasive procedure in an unregulated manner, you would cause more harm. I mean, it's just like performing surgery. You wouldn't dream of performing surgery on an unfit patient. So the same respect should be given to most of your endoscopic procedures. So post-procedure, the recommendations were that following ERCP, a quarter hourly for pulse, blood pressure, respiratory monitoring, plus pulse oximetry. It's done on that basis.
Is that a standard practice in your unit?
Well, sort of. I mean, it's flux. Yes.
Just go back on that slide, please. 4 hours until next day?
If they are inpatients. If they are not, then, normally what happens is, if you do it as an outpatient procedure, they are monitored for 4 to 6 hours in the unit. in the recovery unit of endoscopy.
What's the evidence for that?
Evidence was an NC port study.
Yeah, but that's telling you 7-day or 30-day mortality.
No, but this was just, it was a detailed audit study, so there was a lot of information.
How long ago?
That was about, I think 2004 or 2005. It was quite an extensive, done over 4,000-5,000 patients. So,
Our practice is
no.
Very good.
yeah, for outpatient ERCPs, like the way we do it, we do pancreatic work, we usually get them admitted overnight. And rest of all the patients that were going to outpatient ERCP, if they're going well after the procedure, we monitor them from maybe hour and a half to 2 hours.
Right, okay. We normally, because the recommendation in UK is 4 to 6 hours post-procedure monitoring and then allow home. So if I do the list in the morning, then by 5 o'clock, both of my patients will be home. Like my list inherently was 2 p.m. in the afternoon, so normally we wouldn't send them home after that. The other problem that I have is that in our unit specifically, it's a large rural population. Some of my patients come from as far as 40, 50 miles. They travel on small country roads, so it might take them 1.5 to 2 hours to get to hospital. So if they live far and it's difficult access to the hospital, we admit them.
Yeah, we obviously have a patient who comes for a procedure, they're required to have a driver.
Yes, I mean that is certainly. I mean, you don't necessarily have to follow that, but that was the recommendation given to us. So during, after the procedure, it's important to recognize complications because of the drugs given, if they've had any perforation, like, if they complain of abdominal pain, which is out of proportion to the procedure. Most of the patients would complain of abdominal pain because of the distension caused by air. So you have to be conscious of that. You ask them to rotate the patient around in bed and, pass wind. If the blood pressure drops or the pulse rate goes up, and there's signs of acute hemorrhage, any sign of acute pancreatitis, you start feeling sick, vomit, or sepsis. So something to look for. And normally we give them information sheets, tell them if there's any problem to get in touch with their GP or go to the local ER. Right. Okay. Shall we talk about diathermy or क्या करना है? Sedation नहीं किया अभी, करने sedation पहले करना है, ठीक है. Oops. Right. Sedation and safety in ERCP. Now, again, one of the things that came out of the big audits that were carried out in the UK was that we suddenly found out that most of us were over-sedating the patients. And nowadays, this is an auditable item. I am audited on how much average midazolam and fentanyl arpacidine I'm using in my patients, and it is audited for patients above 70 years of age and audited for those below 70 years of age. So, with sedation, there is a definite risk associated, especially if you over-sedate your patient. And in the past, we found that most of our colleagues, especially the surgeons, were giving 5 to 10 milligrams of midazolam routinely for most of the procedure, whether it was OGD, colonoscopy, or ERCP. And similarly, 50 to 100 milligrams of pethidine, which in most of the cases was excessive. There was excessive use of reversal agents like naloxone and annexate. Nowadays, if you use a reversal agent, well, you have to use it if it's needed, but it is an auditable item. So it is a surrogate marker that you are overusing sedation. So, if you are using sedation, then there must be IV access in the patient. You should insert an IV cannula, secure. There should be supplemental oxygen. If there's any drop, pulse oximetry, BP monitoring is essential. ECG monitoring is not mandatory in all patients, but in some units they use it. We don't normally routinely use in our unit. It's only pulse oximetry and BP monitoring. All drugs are labeled and checked prior to administration. Normally, if I am performing the procedure, the nurses drop the medication, but we check the labeling on the syringe and we check the ampoules that the drugs are within their expiry date, and you actually read out loudly the amount of medication that are in an ampoule, so that there's no, so it's double checked, and usually give them again, NC-POD report, 2004 on therapeutic endoscopy judges, 14% of our cases were over-sedated with very poor levels of formal training in sedation practice. So all this started, the double checking of sedation, the sedatives, the checking of the ampoules, everything started because of that. So we made it a regulation now. So a lot of good came out of these studies. And, availability of BP and ECG monitoring, which was done at that time, most of the units were giving, pulse oximetry, almost 100%. BP monitoring was done in nearly 70%. ECG, about 50%, but as I said, not everyone does ECG monitoring. These are the patients who are high risk, elderly with comorbid factors. So now, obviously, the older your patients are, the higher is the proportion of the patients who needed reversal agent. And as I said, people were giving liberal amounts of sedatives and opioids during the procedures, and more of them were needing reversal agents. Up to 10% patients were requiring reversal agent. Nowadays, hardly ever they require reversal agents because we are very judicious in the use of our sedatives and opioids. Right, so main risk of sedation, as everyone knows, most of the time it is cardiorespiratory depression, hypotension, and it can be sometimes allergic reaction or anaphylactic reaction. So because of respiratory depression, hypoxia, CO2 retention, aspiration pneumonia, cardiac arrhythmias, hypertension or hypotension, sometimes if it is extreme, you can precipitate a myocardial infarction or angina. Sometimes you can get, disinhibition because of benzodiazepines. There is usually benzodiazepine, especially midazolam, is associated with amnesia, antegrade, so they forget about the procedure, even they might have been shouting during the procedure. Nausea, vomiting is fairly rare. It used to be more common when we were using pethidine or morphine, but nowadays we've moved on to fentanyl. It is quite bad with Nubane or nalbuphine. Local reaction at the cannula site, it is more common, used to be more common with pethidine.
Antegrade memory loss 46%, is this based on the current practice where you've gone down with sedation?
No, that was when at the time of the audit.
This is the audit?
That's the NC-POD. Right, now, usually as these drugs are given together, they've got a synergistic effect if you give midazolam and opioid. So we recommend that opioid should be given first. There are two reasons for it. If you give it first, then you require less of midazolam. Secondly, if the patient is going to go into respiratory depression or anything, they've only got one drug on board. So it is easy to reverse one drug rather than two drugs. So you give the opioid first, the fentanyl, pethidine, or nalbuphine, whatever you want to give. Wait for a minute, see any effects on the CO2, pulse oximetry, everything. And if that is fine, then you give your midazolam. Especially when I'm doing colonoscopy, I usually give the opioid first, do a rectal examination, set the patient up, look at everything, and then give them the midazolam if needed. So always give a bit of a gap between the two medications. Don't belt them in straight away. Right? It's just midazolam takes. The other problem is people tend to give high doses because they don't wait long enough for the drug to take effect. The moment they belt it in, they start the procedure. So if you give it a bit of a time, the drug would start working. I think we'll skip this bit, it's just clever stuff. The problem is most of the patients who require endoscopic procedure are high-risk patients. They are elderly, they are frail, they've got other comorbid factors, or they may have old age, obesity, liver cirrhosis, patients who got varices. So you have to be careful. Now, the cutoff point for most of our patients is 70 years. So if they're above 70 years of age, maximum dose of midazolam recommended is 2 milligrams. If I give 3 milligrams to a 70-year-old gentleman, then it is an auditable offense, and we have to fill in an adverse incidence form for that. Maximum dose in younger patients is 5 milligrams of midazolam. Similarly, maximum dose of pethidine is 25 milligrams in 70 years old. Right. Oh, sorry. I'm going back. Right. The other thing to be aware of is the fact that midazolam is protein-bound drug. So if there's any hypoalbuminemia, especially in cirrhotic patients, the effect will be more pronounced. If they are obese, it will be more pronounced. So they'll have over-sedation with it. Opioids are given for their analgesic effect. They can cause respiratory depression just like midazolam, and the effect is summative. BSG guidance, which is British Society of Gastroenterology guidance, is not to use doses of pethidine greater than 50 or fentanyl greater than 100 micrograms, and to reduce the dose by 50% in patients over 70 years of age. Fentanyl is a cleaner drug, quick onset of action, and after using pethidine for almost 25-30 years, I've finally converted to fentanyl now. But I never had any problem with pethidine either. It's lipid-soluble, fast onset of action, and the effect lasts for 2 to 3 hours. The only downside with pethidine was that most of the time it was associated with nausea and vomiting, which you do not get as much with fentanyl. And sometimes it would cause a local reaction at the cannula site. Now, the NC Pod inquiry again highlighted the fact that reversal agents were more commonly used in patients with cardiopulmonary complications. So the use of reversal agents is a proxy for over-sedation and an auditable outcome for the GRS. GRS is global rating scale, which we use to assess the performance of our endoscopist and the endoscopy unit. Reversal agents are flumazenil or naloxone, and you give them, if there is respiratory depression, it's usually presumed that it could be due to the benzodiazepine. So you give the flumazenil first, and the way to do it is 200 micrograms over 15 seconds, and then you keep on observing the effects. Because the effect is fairly immediate. If they are going to recover, then they would straight away. If that doesn't work, then you go to naloxone. If it's an extremist situation, respiratory arrest, then you give them both. Now, what we aim to do is, and in the consent also process, when you are explaining the procedure to the patient, you tell them that it is not going to be, they say that if you give them sedation, you explain to them that it is going to be conscious sedation. They are not going to be knocked out as in a general anesthetic. They are going to be conscious, they are going to be talking to us, but the sedation will minimize their discomfort. So it's drug-induced depression of consciousness during which patients respond purposefully to verbal commands. As soon as the verbal contact is lost with the patient, that is a sign, that is a panic situation. That is something which one should be aware of. Because in conscious sedation, you are not required to maintain a patient's airway or intubate. They are able to maintain spontaneous ventilation. So generally, how do you find out if you've over-sedated the patient? Pulse oximetry is good indicator, but it is usually too late if you notice a drop in pulse in oxygen saturation. The first thing to notice is the loss of verbal contact between the endoscopy assistant and the patient. So if usually our nurses continuously talk to the patient, and so should the endoscopist be. But when you lose that verbal contact with the patient, then that is something to be alerted on. Right, okay. So that's important, right? It's the first sign of impending respiratory depression. So if this is suspected, so at that time when you lose the verbal contact, you should try to stimulate the patient by, shaking them or talking to them. and ask them to breathe. If there is respiratory depression, then you should use reversal agents sooner rather than later, before they get into. So you should give them flumazenil in the first instance, followed by IV naloxone, and if there's no change, if they're not improving, then you should consider assisted ventilation and call the cardiac arrest team. So, do's and don'ts of sedation. Important thing in conclusion is check all expiratory dates, all expiry dates of, check the doses, the formulation of the medication, register all vital signs before giving sedation. So, before you give the first dose of your sedative or opioid, you should check their pulse, the oxygen saturation, pulse rate, and blood pressure. That's all standard given. After you are given the drug, then you monitor the pulse, the oxygen, and blood pressure. And allow adequate time for the drugs to take effect. Don't sort of bend them in. And work as a team with your nursing staff to ensure adequate monitoring and keep verbal contacts. Don'ts of sedation. Don't give midazolam before opioids. Don't forget to continue to monitor observations throughout and after the procedure, and do not ignore the information given to you by the nursing team. Because sometimes I usually see, especially our trainees, the alarms are going off, everything's going off, and they still continue the procedure. If for any reason, because most of your pulse oximeters are set at certain levels to give off the alarm, so if your pulse oximeter is giving off alarm, or if the nurse is, getting concerned about your patient, you must pause or stop your procedure and attend to the patient rather than continue. Right. Now, just some clinical scenario. You've got a 34-year-old man, history of alcohol excess and intravenous drug use. So he's an IV drug user, excessive alcohol, he's abused his body all his time. He has chronic pancreatitis with pseudocyst, tolerated previous OGD poorly, listed for ERCP. How would you approach this patient? It's for you people now to talk back. Okay, fine. Right. Yeah. Okay. Opiates first, then followed by propofol. Okay. Pardon? Okay, fine. Yeah, I mean, that would be the politically correct answer, but usually in our unit, we'll do it, one of our experienced endoscopists would perform it, and we'll still give it a try with, a combination of opioids, and but yes, it might come to a general anesthetic.
I don't do any pancreatic therapy or sedation. Anything like this will not be. So it should be a. Especially, the word of caution here with pseudocystis that the patient
will require.
Patient should be intubated because they sometimes, when you're draining them, there's a lot of fluid that comes out, and there's a
risk of aspiration.
Yeah, so with this history, I think, even without this history, just the fact that we needed to drain pseudocyst and this is our practice.
Yeah.
All pseudocyst, all pancreatic therapies done under sedation. I have not done sedation.
And these are college, they usually end up requiring.
Yes, he's a IV drug abuser as well. So you'd require very high doses of opioid if you need to.
High tolerance.
Yes.
Even the first case, this, if I take a step back, and this patient came to me first time, I'm not touching under sedation period. Anybody who's alcoholic, especially IV drug, no way, I'm not touching. Go to the anesthetist, let them sort it out. I'm only going to focus on my endoscopy, they'll take care of it. It's not my headache. And it's OGD maybe, you can do it, not a big deal.
But ERCP is a major procedure.
You've got a complicated chronic pancreatitis patient. You don't want him moving at all.
Yeah.
So
And if you are performing any therapeutic procedures, then
So that's good.
And what is recommendations for 5 milligram of midazolam and
No, that is the general recommendation. In, special situation, we would go above that, but that is auditable. So I have to explain why I had to give that dose. That's, the thing. But generally, that is just to discourage its unscrupulous use. Generally, a patient who would require more than 5 milligrams of midazolam, most of the time will be done under GA.
And this is for all type of endoscopy procedures, including ERCP or...
With ERCPs, we are a bit more liberal in sedation. But as I said, if we are requiring more heavier sedation, then I would do it under GA. I mean, that is standard practice with us.
I personally feel if I have the choice, I would do all ERCPs under propofol. Life becomes very easy. The last thing you want to do when you're doing ERCPs, especially if they're even a little bit complicated, is to worry about whether the patient is talking to you and what's happening to the lungs. I really don't want to know that.
But then again, if you are doing...
But obviously that's the world where he lives. All these patients I know are done under propofol, under the supervision.
But if you are doing every endoscopic procedure routinely under GA, then you are increasing the risk of GA to the patient's end, and it doesn't become any more different than doing a surgical procedure. So generally, whatever procedure we can do with sedation or conscious sedation, we do that. A lot of our colonoscopies nowadays are done without any sedation of any sort. We just will,
No, I don't have a problem with colonoscopy.
But yes, ERCP, yes, that's different. I agree.
Especially
But
if you've got a training unit.
yeah.
You're training people, it's very uncomfortable for the trainer as well as the trainee and the patient is actually...
Because the overwhelming majority of our biliary work is done under sedation rather than that.
Too,
Yeah.
But I'm just saying, if I had the opportunity, like he has, I would prefer doing it. And certainly they have shown that their practice is no less safe than what we do with sedation. And not only that, but their procedures become much easier.
Right. Case number 2. 60-year-old woman, mitral valve replacement on warfarin, abdominal pain, abnormal LFTs, and recent but resolved mild jaundice, gallbladder stones, 10 millimeter CBD on transabdominal ultrasound scan, suspected stones in the CBD. How do you approach ERCP in this patient? Oops, sorry. Hanji. So 60-year-old woman, she's got mitral valve replacement on warfarin. What should we do?
We have to stop warfarin, switch to IV heparin, hold that heparin 12 hours before the procedure. And for sedation, we can do it in
Acha.
Why not take a step back? Do we for sure need an ERCP? How do we know the stones is not passed? I would do if I had the option, I would do an MRCP.
Okay, fine. Yeah, that's fair comment. Yeah,
MRCP,
because
if
it is a high risk
MRCP is
procedure.
clear, then my job is done. And pass the patient over to the surgeon. I don't have to worry.
Okay,
That was my.
yeah, that's a fair comment. But if the MRCP shows stones, then you are screwed.
Yeah.
Okay. So what do you do then if your MRCP shows stones? If that patient had aortic valve, would your management be any different? Prosthetic aortic valve. How? Replacement. For aortic valve or mitral? Aortic is higher. Okay, fine. Good. Good. Achha. Right. It's a very good explanation, but wrong. Right. Aortic valve, even a prosthetic aortic valve, is a low-risk condition. You can easily stop the warfarin without any consequences, right?
It's a hijack.
It's a hijack.
Low
Yeah.
to the aortic valve is
So,
more high,
the main...
stronger as compared
Yeah.
to this. So it's a less risk of
Yeah.
thrombus on the aortic valve as compared to
Mitral valve.
So you don't have to
So if you have a mitral valve, your mitral valve will seize. Even, it can send off emboli, but it can even stop working, just become clotted, right? So that's even more dangerous. So with mitral valve, you cannot take, it's a high risk condition. So you have to keep them on anticoagulation. So you stop their warfarin 5 days before the procedure. We put them on low molecular weight heparin, which is enoxaparin that we use, a subcut. In the past, we used to put them on intravenous heparin, which was a bit of a pain. But nowadays, everyone uses enoxaparin, or Clexane, as we call it. And on the day of the procedure, you don't give the heparin. You give it later. So that's how.
Let me change the scenario a little bit, Waqar.
Okay.
This patient needs urgent ERCP because there is a stone impacted the distillery. This has got acute pancreatitis.
Right. Okay. Fine. Yeah. How would you do that?
Warfarin is there.
Yeah.
Now what are we going to do?
And that's a very common scenario.
It is. Yes.
It's not like
You don't have 5 days for preparation.
Yeah.
That's what I'm saying.
One at a time.
I would like to go for ERCP
Okay.
and just place a stent.
Okay. Fine. Okay. Fine. Good. That's how you make multiple choice questions. Any other
I
option?
think if FFP is very procedural,
Right.
avoid splenectomy,
Okay.
place a stent, and then electively the whole thing follows, and then later on you can do.
Okay.
In this scenario, you can see the INR range. What is the optimum INR?
Well, if you have got a mitral valve replacement, your TTR, which is target therapeutic range of INR, should be above 3.5. It should not be below 3.5. So that is going to be a very, sort of thin blood. Right. Okay. Any other offers? I think the easiest thing to do is to go down and put a stent in.
Yeah, I think that's.
and
And
you don't have to give FFP.
you don't have to give, because if you give FFP, you are putting your mitral valve at risk.
The point I raised was that can you do ERCP in somebody with a high INR if you're not going to cut?
Yeah.
And the answer is
Yes.
That was the.
Because if you give FFP, then you have to anticoagulate them again, right? So it is not an ideal situation. But you can, yes, put a stent in and that will do the job. Good. 68-year-old man, abnormal left heart, EUS shows 13 millimeters CBD with stones on aspirin and clopidogrel for ischemic heart disease, attends for day case ERCP, normal full blood count and clotting. How do you proceed?
There is no emergency, you can stop it and
In our practice, most of the time we consult cardiologists. There is no acute.
If there's no cardiologist, what do you do?
Then we do ECG ourselves.
Okay, fine. So if the ECG is no
I
money,
have a problem with that. Why is the patient on aspirin and clopidogrel if there is no cardiologist?
the cardiologist has gone home. Cardiologist, you don't need a cardiologist to start aspirin and clopidogrel.
ECG ourselves. If there is no acute insult, then we counsel and then stop and then we move forward.
The cardiologist will be sweating if I change this scenario by saying the stent was placed in this patient last week.
Like the last week, then what
Okay,
you do?
and the cardiologist is going to sweat even if you talk about, you even mention, say to hell with I'm not
Yes, sir.
letting my patient go because of the heart. You saw me with GI.
Yeah, if it's an elective procedure,
Most
then
of the times, clopidogrel is stopped and aspirin is continued.
yes, yeah.
So there is no stop.
And it's
And
depends,
then
when the
clopidogrel
ischemia when the MI is it's in more than 1 year, there's no need to stop at clopidogrel and aspirin. Less than 1 year, within 6 months, we can stop at clopidogrel and aspirin and then.
Yeah, that's correct. Yeah. Okay. Good. 82-year-old woman, metastatic pancreatic adenocarcinoma, frail, marked weight loss, booked for ERCP and metal stent insertion. SEMS is self-expanding metal stent. How would you manage sedation in this patient?
After you talk, it's easy.
Yeah. Right, okay. Less than 2 milligrams of midazolam, probably.
My only concern is if I stop here in Pakistan and say, well, metastatic adenocarcinoma in an 82-year-old. Do you want to put a metallic stent? The patient has said, I'll have to sell my motorcycle and maybe sell some other things to get that metallic stent. I put a plastic stent.
Right. Okay. That's it, folks.
That's a